In this video, we will discuss about the pathological migration. Now, physiological tooth position, it is maintained by the balance between the factors that are the intercuspal relations and pressure from the cheek, lips and tongue, which was illustrated by the equilibrium theory. Now, if this balance is lost, it will lead to pathological tooth migration. Now, how is this balance lost? It can be lost due to periodontal disease or abnormal forces. Now, what is the definition of pathological migration? It is the tooth displacement that results when the balance among the factors that maintain the physiological tooth position is disturbed by the periodontal disease. Now, it is very common and it may be the earliest signs of the disease. It can be associated with inflammation and pocket formation as the disease progresses. Now, pathological migration is seen more in the anterior teeth, and in the occlusal direction, if it is occurring, it is extrusion. Now, how it is different from drifting? Drifting is basically the moving of the teeth into the spaces which are created by the unreplaced missing teeth. They do not result from the destruction of the periodontal disease and may create the condition for periodontal disease. Now, idiopathogenesis. Now, it has a cumulative effect of combination of factors. The two major factors are health and the normal height of the periodontium, and second is the force exerted on teeth. Now, there are two forces. One is the force or the pressure which is given by the lips and cheeks, and the second one is the force of occlusion. Now, force of occlusion also depends upon the tooth morphology, the cuspal inclination, presence of the full component of the teeth, the physiological tendency towards incisal migration, location and nature of the contact point relationship, proximal, incisal and occlusal adhesion, and axial inclination of teeth. Now, coming on to the how is the pathological tooth migration actually caused? So, for either it can be due to the occlusal forces or due to the weakened periodontal support. Now, usually what we have seen in primate studies is that there are transeptal fibers. Now, these fibers they run from one tooth to the another tooth and they form a chain. Now, this maintains the contact between the tooth throughout the arch. Now, if this continuity of the chain is broken or weakened by the periodontal disease, the forces balance will upset and this will lead to the displacement of the tooth. Now, it may even continue after the tooth no longer contacts its antagonist. Now, pathological tooth migration, it is an early sign of localized juvenile periodontitis. The maxillary and mandibular incisors, they drift labially and extrude, creating distance between teeth. Now, either it can occur due to the gingival overgrowth due to drugs like phenytoin and cyclosporin. Now, posterior bite collapse. It is a very important factor. In this, what happens is the contact relationship between the first molar is lost. Now, due to this, what occurs is anterior flaring. And many other etiological factors. So, but there is no prevalence that the posterior bite collapse can lead to the pathological tooth migration. Arch width integrity. Now, occlusal forces are distributed to the teeth in the arch through interproximal contacts. Now, if these interproximal contacts are destroyed, then it will lead to the pathological migration. Now, how can these tooth contacts be lost? Either due to some proximal caries, faulty restoration. All right. Then coming on to in class 2 malocclusion, occlusal interference. There are supraerupted teeth, so consist of elongation of the anterior teeth diagonally. Now, anterior component of force. During occlusal function, it is believed that portion of the occlusal forces is projected anteriorly and has been termed as anterior component of force. It causes the axial inclination of the posterior teeth during occlusal loading. Now, bruxism is a very important factor which leads to pathological tooth migration because it results in abnormal occlusal forces for a long duration of time. Then, shortened dental arches. Dentition, where most of the posterior teeth are missing, they constrict and then they result in loss of molar support. Now, soft tissue pressure on tongue and cheeks. Now, these are very light forces, but they're a long duration. Extrusive forces. Now, these eruption forces are small. Usually, they have a range of 2 to 10 grams and they're present throughout the life. Erupting tooth emerges from the gingiva and moves towards the occlusal contact. Movement is rapid. Now, habits: tongue thrusting, thumb sucking, pipe smoking, bruxism. Unreplaced missing tooth, very important. Now, what happens is suppose you have a first molar missing, second and third molar they will tilt. There will be a decrease in the vertical dimension. Then the premolar it will tilt distally. Mandibular incisor will also drift lingually. There will be an anterior overbite. Mandibular incisors strike maxillary incisors near the gingiva and traumatize the gingiva. The maxillary incisors are pushed labially and laterally. The anterior teeth extrude because of the incisal apposition disappearance. Alright. Then treatment based on severity. Suppose if it is mild or moderate or severe. Now, if it is mild or early, there will be a diastema of the anterior teeth and 2 mm in dimension due to the periodontal disease. So we will do scaling and root planing and flap surgery. However, if it has led to the extrusion and flaring of teeth, then orthodontic intrusive is limited. So we need to have an adjunctive and conventional orthodontic therapy. If there is a diastema of the anterior teeth plus there is 2 mm decrease in the vertical dimension, then we will have to go for prosthodontic treatment. Then recently there has been methods which are employed, which such as reactive repositioning, reimplantation, regenerative procedures like GTR, guided tissue regeneration, bone graft, and PRF. Alright, now mechanism of effect of periodontal therapy on PTM. Now, after doing the therapy, what we will see is there is reduction in the edema and inflammatory cell infiltration, which leads to the shrinkage of the tissues. Now, the healthy collagen fibers, they replace the inflammatory cellular infiltrate. They reestablish normal equilibrium of forces, reactive movement of the migrated tooth into its original position. During healing process, we will see that there is wound contraction due to which repositioning of the tooth occurs and fibroblasts populate and populate the newly formed granulation tissue. Prevention, how it can be prevented is by controlling the periodontal disease, treatment of the occlusal factors and habits, and early detection of the PTM. Now, just to sum up once again, also we can talk about the yes. So now to sum up, the pathological tooth migration is basically when the occlusal forces are high, the balance between the occlusal forces and the physiological tooth position is disturbed by the periodontal disease. Now, many factors, either it can be occurring due to the force or due to the health and the normal height of periodontium. Now, force of occlusion depends upon tooth morphology, cuspal inclinations, presence of full complement of teeth, then axial inclination, proximal incisor, adhesion, migration. Then many factors working. Then coming on to the weakened periodontal primate studies, transeptal fibers broken, balance is lost. Then gingival overgrowth, posterior bite collapse. Then arch integrity, smaller arches, bruxism, anterior component of force, soft tissue presence with pressure, extrusive forces, habits, and unreplaced missing tooth. Then treatment according to the severity. Then mechanism of effect of periodontal therapy for PTM. So this completes the pathological tooth migration.